Good morning and welcome to the UCLA Semel Institute, Department of Psychiatry Grand Rounds. My name is Walter Dunn, your host for today's presentation. It is my pleasure to introduce this morning's speaker, Dr. Boris Heifets from Stanford University. Boris is an assistant professor of anesthesiology, perioperative and pain medicine, and by courtesy, psychiatry and behavioral sciences. Dr. Heifets obtained his undergraduate degree at Yale University and his MD and PhD at Albert Einstein College of Medicine, where his graduate thesis was entitled Endocannabinoids and the Persistent Loss of Inhibition at Central Synapses. Boris then completed his anesthesiology residency and neuroanesthesiology fellowship at Stanford, where he currently resides as a faculty member. He has already accumulated an impressive body of independent work and collaborations, which includes studies elucidating the mechanisms and neural circuitry involved in the prosocial effects of MDMA and antidepressant properties of ketamine. Dr. Heifets is at the forefront of one of the most promising invisible areas in our field, that of psychedelic medicine. Anyone who has done a literature review on the topic will have invariably come across Boris's work, where he has established himself as one of the leading researchers in the area. For his innovative studies with animal models has contributed substantial insights towards understanding the mechanisms and clinical properties of these unique compounds. Not only has Boris published extensively on this topic, but is also in great demand as a speaker. Dr. Heifets presented at UCLA last year for the anesthesiology grand rounds, where he gave a fascinating talk on psychedelics across species. As many of you may know, we are only several months away from an FDA decision on the drug application for MDMA-assisted therapy for PTSD. If approved, this treatment would be groundbreaking on various fronts and could lead the way for an entire class of psychedelic compounds with clinical application. There are many challenges to ensure that these drugs are applied in a safe and responsible manner, not least of which is better understanding how they work and in what context. Dr. Heifets' research will invariably contribute to this understanding, and he will share his work today and insights in today's presentation, unraveling the synergy between setting, and psychedelic states. Dr. Heifets, the floor is yours.
All right. Thanks, Walter, and thanks you all for having me. It's a pleasure to come back to UCLA, even if virtually. I hope to visit you all in person. A couple of disclosures before I get started. I think the key point here is bottom right. I will definitely be discussing off-label and investigational uses of MDMA, ketamine, and psilocybin, and everything that I present is going to be peer-reviewed, or if it's not, it'll be designated as such. So on with the show. So I think that the key message that I really want to transmit today is that psychedelics pose an immense challenge both for mental health care in how do we integrate this new type of therapy into mental health care, and also for sciences, how do we study these compounds? They pose a lot of challenges, not just because of regulation, but also we don't really have the tools. Clinical trials are not well suited to understanding how these things work. So we need some new ways of approaching these questions. And some of these questions are in the title. Set and setting. This is a concept coined by Timothy Leary 60 years ago during the initial psychedelic renaissance. Or I guess the psychedelic revolution. Now we're in the Renaissance. And these are concepts that we'll come back to. So let's start, for those who are not familiar, what are psychedelics? And this is Roland Griffiths, who is the recently passed away and was the former director of the Hopkins Psychedelic Institute, and he really led the way to opening up modern psychedelic research. This is one of the foundational papers. It's in 2006, and it was published in Psychopharmacology. Right. So psilocybin can occasion mystical type experiences having substantial and sustained personal meaning, spiritual significance. So there's something very interesting here already. And this has been almost 20 years, but there's not a word here about receptors, right? This is psychopharmacology, and we're talking about mystical experiences. So already we see a big shift in the framework of what we think about as mechanism and how do we study that. Now, this is, a description from him, which you can read. And, if you're not familiar with the effects of psychedelics, this is I think there are a lot of Simpsons episodes that you can watch to kind of give you some insight. So I'm not going to belabor that point. Very briefly, what do we know about how they work in terms of receptor mechanisms, which is where we're most comfortable? This is psilocybin, the active ingredient in magic mushrooms, and is the furthest along in terms of classical psychedelics. We'll return to that idea later. And you can see it looks a lot like serotonin, which is a signaling molecule in the brain that does a lot of things. The most intense subject of a receptor of interest has been the serotonin 2A receptor. This receptor appears to be responsible for the psychedelic-like effects of psilocybin. Now, receptors don't explain. They explain a little bit. They don't explain. Certainly don't explain everything. So, how is psilocybin being used clinically? And this is just a very broad overview, but the most advanced trials at this point are for depression. And I'm showing you here is this is from 2022, New England Journal, a trial sponsored by Compass. It was the best powered study to date. You can see there's over 200 patients in this, which in psychedelic literature standards is an enormous N. By any other field of medicine is a pretty small N. But what you can see here is this is the change in the MADRS, the Montgomery-Åsberg Depression Rating Scale, which is our typical tool of clinician rated symptoms of depression. And what you see here is that this highest dose, 25 milligrams, which produces, what some people call an ego dissolving experience, separates from these lower doses of psilocybin. So that's for treatment resistant major depression. There's also been trials for major depressive disorder. And again, this is now 3 different phase 2 trials that are heading into phase 3 studies. So this seems to be a reproducible finding. And there are some, when I say controlled, something again we will keep coming back to is how do you actually control for this? Everybody knows that they're getting psilocybin in these trials. So is there an issue with that? So this is probably like the state of the most advanced data for depression. Now, there is also a lot of exploration of other indications. So alcohol use disorder. This is from Mike Bogenschutz, published in 2022, alcohol use disorder. There's also work from Matt Johnson looking at smoking cessation. I think this was the first NIH-funded trial, not this one, but this led to the first NIH-funded trial for psilocybin in modern history. And then for headache, we're also running a trial for chronic pain. People are looking at it for eating disorders. So it seems to be doing a lot for a lot of different disorders, which sort of begs the question of, is there really any specificity to the to psilocybin assisted therapy? So I want to switch gears for a minute and talk about a couple other drugs that I think belong in this class. And the next is MDMA. MDMA has different subjective effects. It has a different pharmacology. It targets serotonin transporters, dopamine transporters. From what I hear, it's a lot of fun. So it has a abuse liability that classic psychedelics don't. And this is my favorite quote on how does this drug work. And this is Sasha Shulgin, who is a pioneering psychedelic chemist in the Bay Area, who wrote a book called Phenethylamines I Have Known and Loved, or PCAL for short. And he called it a low-calorie martini. It opened up a person both to other people and inner thoughts, and decided it might be well-suited for psychotherapy. And there's this encapsulates a lot, actually, in that it's number one, low calorie martini, for someone with an alcohol use background, that might not be such a great thing. And that speaks a little bit to its abuse potential. But also, what do we think it's doing as a therapeutic? Is something about empathy, this pro-social effect of MDMA, maybe driving clinical effects. And this is of all the drugs in this broad class that we'll call psychedelics, this is the furthest along in clinical trials. This is 2 phase 3 studies now published a couple years apart of MDMA-assisted psychotherapy for post-traumatic stress disorder. And what you're looking at is a severity scale on the y-axis and placebo therapy versus MDMA with therapy. And there's a lot of therapy. These patients are generally treatment resistant or treatment refractory before the study. And you can see that this is something that has not been seen before with any other therapeutic. So that's why really there's despite all the issues with interpreting these studies, there's still a ton of interest because we just don't see results like this in mental health. And what I'd like to I'd like to kind of put a box around all of these different therapeutics. And to say that, they don't necessarily share a pharmacology, but what they do share is that they're all powerfully psychoactive, they're rapid acting, and they're durable. So this is one of the early studies of psilocybin and depression. And you can see, again, a single dose of psilocybin, weeks of treatment response for depression. This is another of the early MDMA studies. And I would also, again, even though, the subjective effects don't quite line up, they're clearly not the same drug. They all have this property. They're powerfully psychoactive, rapid acting, and durable. For that reason, I also want to put ketamine into this into this category because it really shares a lot of these same properties. This is the earliest placebo-controlled study of ketamine. And, we can take this up maybe after in Q&A about whether ketamine is really psychedelic. But again, I think it fits these broad categories. And if we're going to include MDMA, we should probably include ketamine. So what is it that binds all of these drugs together? It's really... It's not just, you're not just giving a drug. Psychedelic clinical trials are complicated, and this is part of why they're so difficult to study. This is an example. This is the MDMA assisted therapy for PTSD. This is the trial design. What you see here is, first of all, an extensive screening process, that's highly selecting patients, and then 3 MDMA sessions with hours and hours, tens of hours of therapy. So it's not just that you're giving people MDMA, sending them on their way, and they're cured. There's clearly a lot of things going on here. And I wrote a review with David Olson in UC Davis last year, and this is not a novel concept, but the pictures are novel. We tried to simplify this in looking at each phase of therapy. That complexity can kind of be reduced to 3 basic phases of psychedelic therapy, which have been long appreciated in the psychedelic community. First is preparation, right? You establish rapport, you have a relationship with the therapist, and you set some expectations for what you hope is going to happen. Then there's the drug administration. This is the part we're most comfortable with because it's, that shiny pill at the center of all the ketamine ads that you get online, right? Is the acute. We think that there's some relationship between the acute effect and what happens next. And then finally, there's the integration, right? You have a big experience, and presumably that, you want to take whatever you learn from that and incorporate it into your life. And that's, that requires reinforcement and often requires some support. So how, these things are very difficult to untangle, right? How do you isolate each of these effects and study them? So let's start with the simplest one, the one that we're the most comfortable with, which is drug administration. This very simple question of, well, does the drug matter, and what happens when you take a drug? Drugs, whether you're a mouse or a human, pretty much get into the CNS the same way. But what is it like? How does that acute experience relate to a therapeutic effect? And that simple question is actually quite difficult to untangle. Does the trip itself matter? Right, that has enormous consequences for how scalable is this? Does everybody need to have a 5-hour phantasmagoric experience in order to get relief, or is it something that you could replicate with biochemistry and maybe not have any psychedelic experience at all? So some folks have really taken an engineering approach to this, which is developing non-hallucinogenic psychedelic analogs. What they're doing is they're taking the trip out of the drug. And this is, again, work from David Olson, where they developed a non-hallucinogenic psychedelic analog, and in mice showed that it doesn't seem to, again, mice can't really tell us, whether they're hallucinating, but they don't seem to be having an acute psychedelic experience, but they show signs of therapeutic response. Again, interpreting mouse data is not straightforward. This has led to a lot of work in this area, and this is still We don't know. That's I think the bottom line is, can you really take the trip out of the drug, re-engineer it just for its biochemical effects on neuroplasticity, dendritic sprouting? We don't know. The first trial is actually in progress right now for a compound based on David Olson's work. So we'll see. I think it's a testable hypothesis, and I think the work is important. Now, there's, again, coming back to this idea of, the trip. And if you're thinking about all of these therapeutics, again, schematizing it roughly the same way as before, there's some expectation setting, there's the trip itself, and then there's integrating change. So one way is to take the drug or the trip out of the drug. Another way you can get at that same question is, what if you blank the trip, right? What's another way to remove the trip? So I'm an anesthesiologist. I moonlight, I guess, as an amateur psychiatrist, but I'm primarily that's my day job is anesthesia, and so that led to this approach where could we test one of these psychedelic class therapeutics in patients who are unconscious, right? There's no trip to speak of because they're not aware of what's happening. All that should be left is, maybe just the biochemical actions of the drug, with some caveats. So this is the trial we did. And we were basically asking this question is ketamine an effective antidepressant when given during general anesthesia? We designed this trial. I worked closely with two actual psychiatrists, Laura Hack and Ellen Chatsberg here. We basically were trying to run a psychiatry study similar to all of the psychiatry studies on ketamine that have been done in the last 15 years in the operating room. We enrolled patients with moderate to severe depression with strong elements of treatment resistance. We followed them before surgery, and then during surgery itself, during maintenance anesthesia, we gave them 0.5 milligram per kilogram of ketamine infused over 40 minutes, exactly the same as has been done in other studies. And we took our primary outcome at 1 to 3 days after dosing using a clinician-rated scale, the Montgomery-Åsberg Depression Rating Scale. Cool. So we took the trip, we blanked the trip. So what happened? Well, the first thing that I was very excited about is that the blinding was perfect, right? This is just looking at what, depending on whether they're in the ketamine or placebo group, what did they guess they were in? Patients had no idea. So for the first time, arguably, we have done a trial with a psychedelic class drug where patients actually don't know what group they're in. So this idea of, changing your answers depending on the knowledge, of what treatment group you're in, at least that interaction should not have been an issue. And what did we find? So this was not what I expected. The first thing to note is the ketamine group in orange. The ketamine group folks in this group saw a large and persistent reduction in depression symptoms. A large effect. By that, I mean a 50 to 60% response rate and 30% remission rate. This is on par easily with all of the prior studies. Now, what we weren't expecting is the placebo response was the same size. We were able to, for some reason, drive a similarly sized placebo response. Now, there are many issues with the interpretation of the study, and I'm going to go through them. But what the conclusion I come to after wrestling with this data for quite some time now is that, to me, the most interesting finding here is the placebo group. When the blind is maintained, when patients are not bedeviled by what group they were in and knowing that they were or weren't in a particular group, expectancy, being told that mental health care is important, knowing you're in a therapeutic trial, and having a big event like surgery and anesthesia can have a dramatic treatment effect on par with the effect sizes in every psychedelic study. So that is important. There are major non-drug factors that can account for treatment effects. I was delighted when we posted this. We got a lot of people who thought this was great work, important illustration. Underscore the importance of social psychological dynamics, shows the power of placebo effect, and pretty damning for ketamine. I don't know if I agree with that. I guess I was very excited to see all this, these love notes. We also got some people who really didn't feel that way. I'm a fan, but this is one of the worst studies I've ever seen in psychedelic sciences. No worthwhile practitioner claims psychedelics work without therapy or mindfulness. Here's another one. The study is terrible. It should never have been published, and the conclusions being drawn from it are nonsense. It shows that any mechanism, the only thing it showed is that any mechanism for ketamine treatment requires consciousness. So this kind of hits the nail on the head, actually, kind of maybe inadvertently proving our point. But this provoked a lot of consternation because it's a little bit counterintuitive. And I want to go through a couple of the most common questions, because this trial took a long time to do, and it's going to take a long time to redo a better version of it. The first question that I'm very frequently asked is this just a block of the ketamine effect? Meaning, does anesthesia interfere with ketamine in a way that prevents it from being an antidepressant? So if that were true, then wouldn't you expect that both to be flat lines? Like, why is the treatment effect the same size as pretty much every other trial that I could find? Like, we're looking across 15 years worth of data, we're getting the same effect size. So yeah, it's possible that anesthesia blocks ketamine and placebo replaces them both. Maybe that's not really a parsimonious explanation. So again, we don't know for sure. It's still on the table, but my intuition is that it's probably not that anesthesia is necessarily blocking ketamine's effect, and there's more detail to add there later. The next question is, well, look, both groups got better. Like, clearly it's the general anesthesia that has an antidepressant effect. And to that, I can very unequivocally say no, that's not general anesthesia. I know that there are a couple trials out there, and it's worth looking at them in detail. They do not show that anesthesia in the context of surgery is antidepressant. Here's actually the largest trial. This is from George Mashore and colleagues, looking at hundreds of patients and tracking their mental health in a trial. They were recruiting patients for a delirium study. So they're not telling patients they're in a therapeutic ketamine trial. They're telling patients they're in a delirium study. And what do you see? You see that on post-op day 3, after treatment, most patients are getting worse. There's a higher percentage of patients with depression. And I would just go a step further and say, we know that surgery and anesthesia, like the anesthesia literature, is filled with examples of how surgery and anesthesia have deleterious effects on organs, right? Higher incidence of MI, higher incidence of stroke, postoperative cognitive dysfunction, delirium, kidney injury, lung injury. Why is it that depression is somehow the exception to this? That actually doesn't make a lot of sense to me. And so I would submit that, is it likely that, patients are just happy that they're done with surgery? There's a little bit of that, but that's not accounting for the size of this effect. And on balance, patients, if they were not in a therapeutic trial, would be getting worse in terms of mood after surgery and anesthesia. So then, the major interpretation that's left is, are both of these effects dominated by expectancy? Ketamine never did anything, and it's all placebo. Now that's we don't know. And this is something that we're very keen to find out. So one of the things that we did, at least to get at this, we did not ask patients what we didn't administer an expectancy questionnaire at the beginning. I wish we had, but this was 2019 when we designed this trial. But when we rearrange the data based on their treatment guess, and we're asking them at the end of the study, what treatment do you think you were in? And now you can see there's a separation. And what this tells me is that, again, exploratory data, but that if you got better, you tended to think you got ketamine. And why is that important? Because you attribute therapeutic effects to ketamine, right? You had some prior expectation about the relationship between ketamine and depression, probably an expectation that our research team implanted in the extensive consent process. So there's an interesting counterpoint here. If we think this is expectation, let's look, we didn't modulate expectation, but if you look at another trial, you'll see in a minute. So this trial was done in China. In a way, it was a better study than ours because it had many more patients. There are some differences. It's S-ketamine. They didn't measure blinding. They gave it on induction. I won't throw out our study completely, but what is interesting here is that here you don't see the same placebo effect. And what do we know about ketamine in China? There is a long history of actually government messaging against ketamine, basically decrying its abuse in China. It's an enormous problem. And if you type, this is from Teresa Lee, the first author of our study, she put ketamine into Baidu. And this is the kind of search results she found. This is very different than the kinds of messaging that you're bombarded with. So this idea that this is very culturally, socially determined is what kind of expectations you bring into study. They can potentially modulate treatment response. That's actually not a new concept. So if this is what it looks like in China, this is what it looks like in the US, right? Is that my Facebook and Instagram accounts are, basically littered with promises about the transformational potential of, oral daily ketamine or whatever. Some of this, clearly not evidence-based. So we learned a lot from the study. In particular, we learned a few things that, what do we not want to do if we were going to do this again? And what we're building towards is a study where we're testing psilocybin under anesthesia. This is a tool that has some potential value in dissecting out the trip versus the drug effect versus non-drug factors, right? If we think that this constellation of things are important, well, we need some way to separate them. And this is crude, but it's, let's see how far we can take it. So what do we learn? Number one is that we want to control expectancy. We don't want to have everybody expecting miracles that biasing the results. Another one of the challenges is if you anesthetize someone and then give them psilocybin, how do you know the trip is over? We're not going to talk about that today, although that's we have some answers for that. And the other question really gets at this fundamental issue with this approach to querying the role of consciousness and therapeutic effects. Anesthesia is a drug, and don't we kind of intuit that, well, anesthesia turns off the brain. As an anesthesiologist, I take offense to that. That's not entirely true, but that's sort of the general idea, and it's not off base. So maybe how do you even interpret any of this as a manipulation, because you're just going to turn down psilocybin activity. So this is something that we can actually answer in a mouse, that part of it. And that's what we did. We did a version of this experiment that we're planning to do in a human population, where we gave psilocin, which is the active metabolite of psilocybin, or normal saline. And we either had mice, tripping with their friends or doing whatever they're doing under 1% isoflurane, which is, again, general anesthetic. One way to think about this is really an extreme manipulation of set and setting. Right? Just to kind of harken back to that idea, if we think that the setting in which you take the drug is important, this is kind of a setting of zero, right? You're not there for it. That's kind of the way we conceptualize it. And the specific question, we try to answer a lot of questions in this mouse study, but I'm going to focus on one, which is how much psilocin-induced brain activity is left during general anesthesia. That's one of the main criticisms, again, of this approach. So what do I mean by brain activity? Well, one way that we can measure brain activity is with a immediate early gene called CFOS. And what you see here is basically the CFOS expression is pretty well tied to the number of action potentials that a neuron will fire. And that's what you can see here. So what we do is we basically look at CFOS and we take advantage of some pretty fancy imaging techniques that we've developed in collaboration with others, where each one of these little points of light, this is a mouse brain, an axial section, is a CFOS positive neuron, right? So this is the echo of activity of a mouse taking drugs. We quantify all those. We register them to a standard atlas. We do some warping. We borrow heavily from human neuroimaging techniques. We do some voxel-wise statistics across 8 million voxels. We develop some methods to do multiple comparisons corrections, which I'm not going to talk about unless you really want to. And what's left is a map, right? So this should tell us, like, you can make all kinds of interesting comparisons, like what does psilocin versus saline look like in an awake mouse? What does it look like in an anesthetized mouse? And that should be informative. So we did the study. We were basically asking what is left when you anesthetize a mouse. This is the psilocin versus saline in an awake mouse, right? So this is all the activity, and it's what you would expect. There's a ton of cortical activation, somatosensory cortex. There's some subcortical activation, striatum, etc. So what did we see when we did the anesthetized mouse? So my first reaction was that my postdoc had just screwed this up. These look very, very similar and are clearly wrong. So I asked, like, prove to me that the anesthesia was on, because I think you screwed this up. So this is what you're looking at here is it's the same experiment, except now processed in a different way, where we're looking at what areas are suppressed by isoflurane, all these cortical areas, exactly what you'd expect, and what areas are what areas are activated. And what you see here broadly is that anesthesia, and this is again something well known in the anesthesia literature, you basically redistribute activity from the front of your brain to more hindbrain areas, and that's very much what we see here. So the anesthesia was on, thank God. So what do we do with this map? Like, this is, again, it's actually there's it's pretty weird. I'm flipping back and forth, awake, asleep, awake, asleep. And there are a couple of things to note. The first is that when we look at the asleep mouse, we actually had to turn the correction factor up for multiple comparisons, meaning the signal to noise for CFOS was actually better when they're under anesthesia, which is, again, not really what we like. Why would that be? The other thing that we noticed was that there was like about 90% overlap in the kind of brain activity we see awake versus asleep. Again, these broad swaths of somatosensory and motor cortex. But there's also some chunks that are curiously missing, right? It's almost like there's a selective ablation of some of these anterior areas. What are these anterior areas? Places like the anterior cingulate prelimbic. So that is also interesting. What do those areas do? And when we look, so, we designed the study as a 2x2, right? Anesthesia, not awake, and psilocin, saline. And we can look at the interaction, right? What is an interaction? It's how does anesthesia change the effect of psilocin? And when we look at that interaction, now this probably doesn't mean a lot to you, but I want to point out that we've done a very similar experiment before. What we looked at is psilocybin in an enriched environment versus a home cage. So what we're looking at here is in two different experiments done 2 years apart. We're looking at the interaction between setting and psilocin or psilocybin. And what just shocked me is that this little nugget of tissue that you can see, this is the anterior cingulate. It showed up in an unbiased voxel-based search, across both of these experiments as a source of interaction. Meaning, if there is an effect of if brain activity is modulated by setting, it's almost certainly has something to do with activity in the anterior cingulate. And this is a brain area that keeps popping up in basically every imaging study ever done for psychedelics. So that's, again, this is still mouse work, and the next step is to look at this in humans. So there is another kind of, in my view, weird implication of this data. I'm looking at this map, and what I see is a mouse that's anesthetized, but its brain is on fire, right? It still has all the somatosensory and even actually like motor cortex, not motor output, but still there's some input being sent to the motor cortex. Is this an experience? Like, what is the state of consciousness even? And the only way to answer this really is through a human experiment. But I'm going to go out on a limb here and draw some connections here. So this is all CFOS data. This is looking at basically collapsed activity over a few hours to generate a single map, a difference map. The other thing we did is we collected EEG, and This is something that I found fascinating. This is looking at the alpha and theta bands in mice, right? And this is true whether we looked when mice were awake or when they were anesthetized. What you can see here is that the blue arrow is when we administered psilocin, and you can see this consistent drop in both theta and alpha power. Now, what is that? We don't really know what that is. That's the alpha is is a conglomeration of all kinds of subcortical and cortical activity. But what's is as a biomarker, it is very curious to me that this is from Chris Timmerman and colleagues in the UK. They saw something very similar in DMT, and this has been seen in other psychedelic studies too. Now, what's notable about this? So let's just think for a minute about like what might a mouse be experiencing, what might a human taking DMT experience. And DMT is one of the most potent psychedelics known, and it's so potent that what people report is basically being totally disconnected from external reality, right? And everything they're just having a very intense internally generated experience with elves and aliens and whatever, all kinds of all kinds of fantastic imagery. And what you see on DMT is this same thing. There's a massive reduction in alpha. We see the same thing in mice. Now, again, this is almost happenstance, but we have seen something very similar in a particular state of consciousness in humans. And this is during emergence from anesthesia. You'll see the link, I hope, in a minute. But what you see here is this is classic deep and or surgical anesthesia, where you have a patient here who has prominent alpha waves. And then this is the path of emergence. And one of the things that happens during this period, they're not awake here during 3 and 4. They're not responsive to external stimulation, but the alpha band disappears. And this is something that is highly correlated with something called dreaming, disconnected consciousness, right? How interesting. So now the question is, how deep does the parallels go? And that this is really what I'm focused on. So there's some clear links between the phenomenology of dreaming and the phenomenology of psychedelic experiences. I'm showing you here that there's at least some link, maybe superficial, in physiology. What about therapeutic potential? So I'm just going to preface this by saying these are so far case observations. This is not randomized controlled data, but it is unlike anything I've seen in an operating room ever. And it gets at this question is, how can is there something special about psychedelic states that makes them therapeutic? Is it something special about the drug? Or what if you could achieve the same type of transformative change and getting better from a psychiatric condition without use of psychedelics at all, but achieving the same type of state, right? So now state being more important by the path used to get there, more important than the receptors used to get it to that particular condition. So this is already a few years ago, but this is the first case report that really sparked our interest in this idea. This is a woman who came to us. She's 26. She was attacked by a relative at close quarters. And as you can imagine, extremely traumatic experience. She had 12 days of nightmares, sleeplessness. Basically, she met criteria for acute stress disorder. This is someone who I would typically imagine would easily progress to post-traumatic stress disorder. We caught her within a window that was still the acute phase. She came to our surgery center where she was basically put on. She had a block, meaning her arm was blocked, had a nerve block, and we had a light anesthetic. This is a picture of the blood-brain barrier. This is where we usually live. And we're collecting EEG, and a lot of credit, massive credit to my colleague Harrison Chow, who's been doing this sort of dream induction for years, partially as a curiosity. But he did the protocol here. He didn't really tell the patient that we're hoping for any particular outcome. He said you might dream during this this monitored sedation. This is this patient's EEG during emergence from anesthesia. So what you see here is, again, propofol sedation, classic sedation. And then right around 3, again, I say REM-like really only in the sense that there's high frequency activity. We don't know if this actually represents REM, but based on what she tells us later, the somewhere in this 10-minute period, we think she's having a pretty intense dream. And then she wakes up and her heart rate goes to 130, and she's now telling us some pretty intense things. She immediately recalled having the same nightmare that had been looping every night but never going to completion. This time she had it again, and instead of stopping at the moment of the attack, she dreamt of going to the emergency room. She dreamt of going to the operating room. She dreamt of going home and using a repaired hand. And we followed her for a day, a week, a month, a year, 2 years, and she doesn't have nightmares. She's able to talk about this experience like without the kind of activation that you might get when you ask a vet about, tell me about the war. This was remarkable. Again, N of 1, so who knows. Now, based on this, we basically started a quality improvement program of slow emergence, trying to target this dream state. We've done this over 400 times at Stanford. So IRB exempt quality improvement research. And we happened to get in our patient population 2 patients who met criteria for bona fide PTSD, pretty severe dysfunction. And this is just published in the American Journal of Psychiatry last couple weeks ago, where we had 2 patients who were surprisingly similar cases. Both of them had lost adult children to suicide or drug overdose, and both had just months or years of nightmares. And they both met criteria for PTSD prior to surgery. They're coming in for surgery for totally unrelated things. One was having a breast biopsy, the other was having a thyroid done. And we basically induced this dream state at the end, this prolonged dream state. This isn't just a fleeting, as you wake up from a deep sleep. This is, we're specifically targeting a particular waveform on our EEG monitor, and we're using anesthetic to stabilize that state. And again, this to me begs for controlled studies. What we're seeing is a narrative that sounds so much like what people describe from MDMA that it is hard to ignore the parallels between this and psychedelic-like transformations. One patient you can read on the right, like this is a very kind of sterilized and academicized version of what her dream was. I mean, it gave me goosebumps to listen to. She woke up, thinking that her deceased child would be in the room with her, and thanking the anesthesia team for giving her that chance for closure. Again, I should be skeptical when people tell me stories like this, and if I had not heard it with my own ears, I wouldn't really believe it either. But this happened. We have documentation of it. And it speaks to this idea, like we've, there's no psychedelic involved here. There's no ketamine involved here. This is really just propofol for the most part, where we're inducing a particular state defined by EEG that's called disconnected consciousness, right? And holding that state for long enough for internal content, for memories to be reconsolidated in a way that's beneficial. So, going back to this broad idea of, how do we deconstruct the psychedelic experience? Looking at the way these trials are run, all of these elements are present. And, so far we don't have a lot of tools to untangle them. My suggestion to you is that, over the course of this, last 45 minutes, I presented at least 2 ways to start to separate out these components and really start looking at which aspects are necessary and sufficient to account for these transformative changes. So one thing I showed you is ketamine during anesthesia, where we showed what that demonstrated, the placebo effect we generated, I would argue to you, shows the influence of non-drug factors, shows just how large non-drug factors can have in therapeutic change. The dreaming studies that I showed you, that again suggests that it's not so much the that you can achieve very similar effects to what's seen with psychedelics by not necessarily with the use of psychedelics, that there's maybe not anything inherently special about the serotonin 2A receptor. It's more about how do you generate an experience of sufficient magnitude and salience that you can then use that to effect a therapeutic change, therapeutic growth, and transformation. So in broad strokes, I think that the main messages that I want to transmit are these. One is the mechanism does matter. It has enormous implications for safety, right? Like, how are we going to administer MDMA assisted psychotherapy to 25 million patients with PTSD without a supply of therapists that are, capable of delivering it? I don't know. Right? So that leads to the question is, well, do you need to have this like whole trip and this, the vulnerability and all the things that go along with psychedelics? So we need to test those predictions, right? Like, we need tools to investigate those questions in a rigorous and reproducible way. And the other point is that, translation, now is the time. Like, the pendulum will swing back. We can learn a great deal about the mechanism of how these drugs work through very, carefully considered animal trials and human trials. And now is a time really to make those predictions and test them, and understand the role of biochemistry, understand the role of experience itself in affecting therapeutic change. So probably more questions than answers as usually, but that's it. This work, I would want to take a minute here to thank all. This is an enormous team across my lab and across multiple collaborators. In particular, the Dream Team down here in the right corner has been basically doing this on a shoestring budget, and of course NIH for funding the animal work, most of which I didn't show you, and my department. So thank you very much for your attention, and I'm happy to take any questions.
Well, thank you, Dr. Heifets, for a fascinating presentation. Before we begin with the question and answer session, I'd like to introduce and bring in Dr. Anya Prashad. She is a recent graduate and the newest addition to our faculty. She, in her own right, has done some incredible work involving psychedelic medicines, and she'll be joining us as a guest discussant. So I'm going to take the prerogative as the host to ask the first question. So I want to segue from your dream, the anesthesia stabilized dream. So the MAPS folks, when they do their training for their MDMA PTSD treatment, they talk about the innate healing power of the mind, right? And that you're just setting the right conditions for, your internal abilities to heal itself. And so I'm wondering, is that a potential mechanism about your anesthesia stabilized dreams, that you're just allowing the patient to complete the dream, that in kind of a non-anesthesia condition, the dream wakes them up. It's always kind of, it never comes to completion. There's never a satisfying conclusion for them. But because you're using your drug, you maintain them in that state, and whatever activation would have woken them up, is suppressed, and they're able to come to completion. Because my understanding is that pre-surgery, you're not setting up a mindset or expectations or talking about how they should dream, maybe in a kind of image rehearsal therapy type of approach. It really is, we're gonna do this, and the journey is yours, and whatever transpires. Can you comment on that?
Yeah, I mean, I think you hit the nail on the head, is that this idea, one of, I think, the biggest tensions in this field right now in terms of like drug development and how the industry is going is this neuroplast, is a very vague term. Like, are you growing stuff and like endowing someone with something that they could not have done on their own by, sprouting all these new connections? Or are you allowing someone to basically reintegrate their, image of who they are, through by catalyzing, right? Are you catalyzing a healing process? So I hesitate to use the term inner healer because there's some things that are not amenable to inner healing. But yeah, that's basically what we believe we're doing, is that we're catalyzing a process by, giving space for all this internal content to come up. And, again, thinking very generally, it's very easy to conceptualize psychedelic therapy more broadly as the same sort of process. You're basically, allowing content to issue forth that then is, therapeutic. Now, I'm not a psychotherapist, but that whole idea of like, this focal point for change, and that sounds like, a very like a cornerstone of psychotherapy, that like you have a big event and that, something happens. It could be a heart attack, it could be jumping out of a plane, it could be a bar mitzvah, right? It's like all of these things are, that's an ancient idea, is that you have some transformation that's catalyzed by an event. To your, I think I covered and went past some of what your question was. I don't remember if there's another piece to it.
No, that's perfect. I want to go back to the beginning of your talk when you were referring to the non-hallucinogenic compounds that are currently being developed. I'm wondering, and I'll bring Anya into this conversation. So obviously this can be done with microdoses, right? Doses at which the patients aren't having a quote unquote psychedelic experience. Have you done those types of studies at doses where it's not causing some type of experience in your animal models?
I have some bad news for you. I don't think any of this stuff works. I think it's mostly, I mean, it's again, to the extent that, it allows people to set expectations and have a focal point in their lives to drive transformation. Like that's real, right? You can't deny that is a mechanism of change, but does it have anything to do with the biochemistry of like this drug? It seems very unlikely. Most of the evidence that has been collected so far suggests probably not. Although there's some, maybe some caveats there. It's I would say again, difficult to study and very much confounded with the expectancy effects. And I'll leave it at that.
Dr. Bashar, do you have any comments on that? I know your own research and a lot of the published literature out there really haven't shown a benefit for microdosing, yet anecdotally, right, you just hear these fairly incredible stories. What are your thoughts?
Yeah, I think that's a really it's been a very difficult question because of this relationship with kind of the set and setting and the outcome of these trials. And people argue that in a laboratory setting, we're not producing all the effects that are necessary to produce what people anecdotally report. But I will say that in our studies with microdoses of LSD, it is the doses that kind of edge toward higher doses and detectable doses that are actually most effective in producing any kind of mood effects. And that's what we found with small doses of LSD. And some people have said, oh, the doses you found effects on aren't exactly microdoses, they're a little bit higher. And that's exactly what we found, that as you get to a more detectable dose, you create a more positive mood effect.
Right. Yeah, my impression, just looking at the literature, is that these are true microdoses. Yet when you talk to people, again, who are using anecdotally, they're clearly having an acute subjective effect, not to the extent of a full psychedelic experience, but they know they got something. So I'm wondering if that explains the disconnect between the literature and just people's experiences. Before the grand rounds, we were talking about the potential negative downsides and risks of these compounds, and we have a question regarding your dream anesthesia study. Have there been any nightmares or negative experiences in the extended anesthetic procedure?
So I'll say something that I said before, which is that any sufficiently potent treatment almost certainly has potential for harm as well as good. We have strangely we haven't observed it. I'm totally speculating. There may be a role of the drugs themselves in just limiting. These aren't really uniformly positive experiences. That's actually what I want to say, is that, they are actually re-experiencing nightmares to some extent, right? Some of these patients have the same nightmare, but because, as you put it, Walter, we're basically dampening all of that arousal that would normally rocket them into consciousness. They're able to it peters out. And then now it's just content that's being reconsolidated in a more neutral setting. The salience is really what's surprising in these patient encounters. We've not had anyone who seems to have been harmed by this, but again, that's something that if we do randomized trials, which we're planning right now, that is 100% on our radar, where we have to actively assess for the capacity for harm.
We got a couple of questions regarding the initial ketamine study. So I'll group these together. Number one, did you assess patient preferences for ketamine versus placebo? And then what type of expectations were set for patients by the study staff?
So in the ketamine study in particular, we selected patients for whom there was equipoise. And typically we don't consult with patients on what anesthetic we're gonna give them. It's too much information to give someone, and usually they're not very well informed about the ins and outs of each anesthetic. So that's that's basically that's how we standard clinical practice. We picked cases for which there was no specific indication. So, for example, patients who came in on very high doses of opioids, that is a soft indication to actually use ketamine, where ketamine can reverse opioid tolerance, for example. So those patients were out. But we did not ask patients ahead of time which one they preferred. We informed them we were randomizing them. In terms of the dream studies, and as I mentioned and show the data, but we have these 400 patients in a case series that we're working up. There's no, we're really sticking to standard of care here. We're informing patients about the possibility of dreams, mostly as a way to temper anxiety about if you remember something as you're waking up from anesthesia, that does not mean you were awake during surgery, which is a very different thing. No one in this study has yet reported any anesthetic awareness under general anesthesia, which is a very that's like a big deal in the anesthesia world. So we're not priming them for a particular experience.
And following the dream studies, another question: is there a hint of exposure therapy in this prolonged dream state?
Well, what is exposure therapy? Isn't that basically what I mean, that's kind of, a recurrent intrusive thought that you can't get rid of, that just doesn't, you can't hold in place long enough to process it. How do you give someone space to do it? Either you bombard them with it, with a psychedelic, possibly, right? We're doing a chronic pain study right now, chronic low back pain. And I don't think I'm, breaking any confidentiality. I would say, one of the patients in this study, talked about as if, she was confronted with her pain and, and was able to, like, what are you doing in my body? Like that kind of experience where, you're in a state that allows for that type of emotional processing that maybe would not be possible even with the best. Maybe a very skilled psychotherapist could do it, but that takes, let me just actually put it a little bit different way. I think that these treatments, like the psychedelics, dream therapy, are approximating a first approximation of what real human experience might be like, a transformative experience. We're allowing space for something that could happen naturally, but just because of the way our lives are structured, it doesn't. And so we're kind of getting people a little bit closer to allowing that to happen.
And going back to the title of your talk, the set and setting. So as we are approaching the quote unquote finish line, some may say the finish line, but I actually would say that that's actually the beginning of the more interesting aspect of psychedelics, is the real world kind of above ground application. And so the FDA will regulate the drug, but really the set and setting are that important, right? The prep sessions, the integration sessions, that traditionally has not been under the realm of FDA oversight, right? That's technically practice medicine. And what are your thoughts on how that could be regulated, if it even can be, and opinions and thoughts.
This is pure opinion. I also want to invite Anya to opine on this. There we go. Sorry, a little bit more light. That I have no idea what the FDA is going to say, but I'm pretty sure they're not going to start regulating psychotherapy. That's probably not going to happen this time around. It is very clear that there are risks with MDMA that are not well addressed by the current regulatory structure. What do I mean by that? Is patients are in, vulnerable patients who have tried everything, are this is a last ditch. This is like after all the other therapies, they're putting their hopes on this, and you're putting them in a suggestible state with people that they have to trust. And how, that is, how do you manage that risk? There's inherent risk in doing that, whether you're talking about MDMA or just regular psychotherapy, except now that you've added, you've layered on additional risk factors. I think it is critically important that there either be state guidelines, for example, like practice boards, that determine like what's appropriate, allowable, like where, some sort of regulation over that process. It's not going to come from the FDA. It'll probably have to be local.
Dr. Prashad, your thoughts on this, since you've actually worked with healthy kind of volunteer populations and perhaps not as susceptible, but under the influence of these compounds, perhaps there's going to be also risk there.
Yes, I mean, I want to emphasize the importance of studying the different types of interactions between psychotherapies and these substances, which we haven't done much of. Most of the clinical trials have had kind of a prescripted, either a prescripted type of psychotherapy that's kind of predetermined, or a kind of looser psychotherapy where we don't exactly know the specific components involved. And I think it's so important that we really invest in research and of pulling apart the necessary components of the psychosocial aspect of these treatments.
Great, fantastic. Well, I see that we're at the top of the hour. I want to thank Dr. Boris Heifets from Stanford for a fascinating presentation, Dr. Andre Burchard for being our guest discussant today, and then obviously to our audience for fantastic questions. Thank you very much, and we'll see you next time.
Thank you.